Welcome to Evaluating the Patient with VTE. In this episode, we're going to be identifying appropriate risk assessment strategies to accurately determine the level of DVT and particularly pulmonary embolism, which will be the focus here, the risk for patients. As we get started, I want to mention that this series is supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance, and the views and opinions are those of the speakers and reflect the synthesis of science. Content should not be considered as the official policy of the American Heart Association. I'm Kenneth Bauer, and joining me is a distinguished multidisciplinary panel. I'm a hematologist. We also have Dr. Erica Shore, who's a PhD in nursing, and Dr. Daniela Kadian-Dadov, who is a vascular medicine cardiology specialist. Through this podcast, we're going to present a case and discuss risk stratification, particularly with respect to pulmonary embolism in the case we'll be presenting, treatment options for acute pulmonary embolism, more standard therapy with anticoagulation, and then actually discuss the risks for venous thromboembolism as to why actually people get venous thromboembolism. So let's start with a case. This is a case of pulmonary emboli. A 36-year-old female is brought to the emergency department with a one-day history of progressive shortness of breath and pleuritic chest pain. Her vital signs showed a rapid pulse of 142. She's in respiratory distress with a respiratory rate of 38. Her blood pressure is okay at 128/94. And her body mass index is elevated at 35.5. Her oxygen saturation on room air was 75%, quite low. A D-dimer was very elevated at over 8,000. Her lactate was elevated at 3.7, and a pro-BNP level was 2,636, again, very elevated. She underwent a CT pulmonary angiogram, which showed pulmonary emboli with a saddle embolus, an extension into all lower pulmonary arteries. There was evidence of right heart strain with interventricular septal flattening and right ventricular atrial dilatation. Her risk factors for having developed pulmonary emboli were use of an oral contraceptive for 10 years and her weight. There was no prior family history of venous thromboembolism, nor a prior personal history. She was started on a heparin infusion, and the rapid response team, if you will, a so-called pulmonary embolism response team at this medical center, a so-called PERT team, was consulted. Shortly after the heparin infusion had been initiated, the patient became hypotensive with the blood pressure dropping to 90/60. So in talking about risk stratification, maybe I can turn to Daniela with regard to the approach to such a patient with a large burden of clot due to pulmonary emboli, who's exhibiting some worrisome clinical issues with respect to her respirations, oxygen saturation, blood pressure, as well as some of the biomarkers.
Thank you very much for that. It's a great case. So I think first off, it's important to remember that there is a spectrum in the presentation of patients, and it is a continuum, and a patient can move within that spectrum at any point in time. So when you're first assessing the patient clinically, you have three varieties at which you can assign the patient, as shown here. The so-called massive or high-risk PE is that patient with hemodynamic compromise and evidence of RV strain or failure. That's associated with the highest rate of mortality, and often advanced therapies are required to resuscitate the patient. The submassive or intermediate risk PE is a patient with evidence of RV compromise, but who's still hemodynamically stable. So kind of walking that line, that cliff, if you will, still holding out. There is some evidence in the literature that markers of RV strain can be additive for patient in terms of identifying them as lower versus higher risk within this intermediate risk category. So if they have both evidence of RV dysfunction on imaging and positive biomarkers, they're considered higher risk as opposed to only one of those. And this patient that you presented had both. And this is related to a kind of higher risk mortality, certainly up to 15% or so in the literature, and these patients are often considered for advanced therapies. And then finally, the low risk PE who has no evidence of RV dysfunction and is hemodynamically stable, very often has an excellent prognosis with just anticoagulation, and many can be treated as an outpatient. Risk stratification scores like the pulmonary embolism severity index can be really useful to identify which patient you may be comfortable treating as an outpatient. But I think important in the case you presented is we had a patient who presented initially as intermediate risk, and then along the course of her therapy, it sounds like started tipping over into the high risk massive PE category as she became hypotensive.
Yeah, so these are oftentimes difficult, particularly the middle ground, whether they're sort of in this intermediate group who have submassive. It really looks like she's trending more towards the massive side, and it really opens up really the issue of whether this kind of patient really needs more than heparin. Certainly, I think that's a very serious consideration, and maybe you could describe a little bit about, per teams, in terms of, rapidly assembling a virtual consultative team, because there are a lot of stakeholders who manage VTE. I have on the next slide, actually, a series of options and the number of specialties that can be involved in this. Of course, these patients will be in the intensive care unit, generally critical care physicians who are pulmonologists, but sometimes they're in the cardiac care unit and cardiology too. Before they actually get to the units, they may be under the care of the internist. Hematologists may be called in to weigh in, although, sometimes the issues there are related to weighing off bleeding risks. Maybe you can take us a little bit through a little bit of some of the advanced therapies as opposed to standard anticoagulation.
Yeah, happy to. Thank you. So I guess first, when you think about the treatment of venous thromboembolism, there are really two goals. The first is to reduce mortality, which we can do with anticoagulation, reperfusion therapies, whether it be systemic or catheter-directed lysis, and then potentially, and also surgical, intervention as well would fall under that category. And then role for potentially IVC filter in very select patients. And time can very often matter for these patients. And so that's where assembling a multidisciplinary team to talk through the options can be very effective and has been shown to reduce mortality and improve outcome for these patients with pulmonary embolism. The second goal of therapy is longer term, and that's the prevention of chronic thromboembolic pulmonary hypertension, and doesn't really apply in the acute setting. But when you're thinking about the options for advanced therapies, I think it's very important to try to get the stakeholders together. Our institution also has a pulmonary embolism response team who reviews these cases in rapid time and can help to expedite the patient through to the appropriate level of care or whatever's decided upon by the multidisciplinary team. I know a lot of places don't have access to a PERT yet, or maybe are in the early stages of forming one. And in that scenario, I think just starting by identifying the stakeholders and getting the back line to talk about these urgent cases is very important.
Yeah, there are clearly a number of options that are laid out there besides anticoagulation, thrombolytic therapy. The issue with thrombolytic therapy always has been particularly the risk of intracranial hemorrhage with full dose thrombolytics, even with TPA, and the failure of the trials, at least, to really show a mortality advantage. Clearly, you can resolve clot. Now we have these more modern therapies with catheter-directed thrombolysis, sometimes with ultrasound, mechanical thrombectomies, a number of newer devices, and these become individual decisions, regarding these therapies. And I dare say the one thing I think some of the catheter-directed approaches perhaps, perhaps of mitigating some of the lytic therapy related, disastrous complications, particularly intracerebral bleed. This patient is young, doesn't have contraindications. Sometimes we have patients who've just undergone major surgery where there are bleeding risks, particularly with thrombolytics, maybe less so with catheter-directed thrombolysis, but it's still a consideration. Another important issue, though, perhaps in patients who are not quite as unstable as this patient is, but people who are reasonably stable, but have very large clot burdens, is patient preference. Many of these people are older, have other comorbidities. Cancer is a major risk factor, and whether they really prefer to really go to more advanced therapies if they're, clinically reasonably stable, and patient preference comes into play in a big way, as well as, what their goals are. Maybe Erica, you can comment a little bit about that issue of, really what the patient wants, given that, the evidence as to, this tipping point between intermediate and high is not so straightforward.
Yeah, and I just want to back up first and talk about nurses' role, because oftentimes it's going to be the nurse at the bedside that's responsible for detecting those subtle or maybe more obvious changes as a patient moves along the spectrum of risk, and then notifying other providers in the healthcare team to take appropriate action. And I'm glad you brought that up, Ken, because better outcomes are definitely observed when providers engage in discussions with patients about their treatment options and learn about those preferences that they have prior to implementing therapies to treat VTE. And I think that nurses play a really important role in having those conversations, at least getting those started, and educating patients on physical and pharmacological prophylaxis. But as Daniela was talking about, adherence to recommended treatments is important, particularly when you have more advanced therapies that are needed. So it's important to have these conversations with the patient and or their family members so that we can have the best outcomes possible for these patients.
Moving down a little bit, one of the elements that sometimes comes in, particularly if people are highly unstable, have a large clot burden where there's fear yet additional emboli from the legs or even the cava will cause them to really decompensate to the point that they become hypotensive and go into shock or really respiratory failure, is issues of IVC filter. I dare say, that oftentimes one will, if one is able to get ultrasounds of the leg to see whether there's thrombi in the lower extremities. So that can sometimes be incorporated, particularly if people are going for interventions where there's concern that they may dislodge other clot, which may travel to the lungs. Surgical embolectomy is usually used for the most extremely ill, and ECMO for those people who can't be supported, on a ventilator or have decompensated cardiac-wise. So it really takes a team. IR is very much involved in all of this too. For the people who are more on the right side of that spectrum, the low-risk people, the people who are intermediate, who are not have stable vital signs and don't have worrisome prognostic features, anticoagulation remains the mainstay. And after acute therapies, if somebody's advanced to advanced therapy, they go on to anticoagulation. There are multiple approaches. As you can see, we have two drug approaches. The traditional heparins, low molecular weight heparin, or fondaparodox followed by warfarin, or some of the direct oral anticoagulants, dabigatran and doxaban, which were not trialed by using monotherapy, by using the oral agent initially. And then we have the two monotherapy approaches, rivaroxaban and apixaban, where there are loading doses, if you will, for 3 weeks with rivaroxaban and 10 weeks, one week with apixaban, followed by long-term therapy. So, patients generally will get a minimum of 3 to 6 months. The oral therapies have really transformed the management of VTE. But I dare say, going back to our extremist patient, we generally those people are put on fractionated heparin because of the fact that it can be most rapidly monitored and titrate in the acute setting, and you have better control there. So let me just sort of wrap up this discussion, as to the issue of why people get thrombosis. This is a sort of a slide of the fact that venous thromboembolism is multifactorial. Maybe Danielle and Erica, you can take us through a little bit in terms of the pathogenesis of why people get VTE in the first place.
As you said, it's often multifactorial, and there are some factors at which we're able to identify and likely some that we're not. So when it comes to assessing a patient with a venothromboembolic event, trying to identify risk factors that are modifiable is very important for their longer term, and also in reducing the risk for recurrence. And then also identifying those that may not be modifiable, because that will also have an impact on your duration and intensity of therapy. And so as you've outlined, there are genetic markers which we know how to look for. They likely represent the tip of the iceberg. I think there's likely very many more that we don't know how to test for. I think it's important to recognize that many of these cannot be tested for in the acute setting, because they will be abnormal in the setting of active clotting and anticoagulation, particularly the protein CNS and antithrombin, as well as lupus anticoagulant may not be accurate in the acute setting. And then going down the list, thinking about triggering factors and exposures that may be transient that you can remove, again, become important in terms of preventing longer term risk.
Yeah, these are usually downstream decisions. This case, the woman had oral contraceptives, even though she was on it for a decade. It still constitutes a risk factor, and arguably one that can be removed, which would be the standard of care if somebody has an oral contraceptive-induced thrombosis. And obesity also played a role here too, but again, there's more to it than that. Subsequent evaluation would be downstream, hopefully once the patient is stabilized out of the hospital, and evaluated for other risk factors and decision of whether she needs long-term therapy or whether therapy can be ended after 3 to 6 months. But these will all be based on really how she does ultimately. Erica, do you have any other thing you want to add about the case before we wrap up?
I think Daniela did a nice job. I just wanted to highlight that we know when patients are in those situations after major surgery or an injury or during those periods of infection or inflammation, that's more frequent assessments required for DVT and or PE. And I think, again, that's a great opportunity for education for the patients about the frequency of those assessments, because of these particular situations put them at a higher risk for this complication.
So let me close then. I want to thank the panel of Erica and Daniela and the American Heart Association. This series is available through major podcast platforms. To claim credit, visit learn.heart.org and stay tuned for future episodes.